This is Rajiv Tandon here. Having been associated with the process, I think the primary driver for the process is really a concern question about safety of children, about their appropriate utilization. And certainly one of the drivers from a Medicaid perspective is efficient utilization of medications. And so cost is a consideration. But I don't think that's what's driving this particular process. I think the issue really is, as you point out, there are data about the use of these medications, but inadequate data. There aren't a whole lot of data about the long-term effects, there aren't extensive clinical trials of these medications in this particular population. But there are data. It isn't fair to say that there are no data whatsoever. So I think we should be guided by some critical considerations. Firstly, looking at all the data that are available, given the constraints of those data. Secondly, recognize that there are different safety efficacy considerations in this particular population that we need to be cognizant of. And thirdly, while not interfering with the locus of decision making, which is the physician with the parent and child, I mean, that's where clinical decisions are made, and physicians are well qualified to make those decisions, and parents should be provided with all the information that they need to have to make reasonable decisions in the interest of their child. That's where the decision making is. However, I think it behooves us, A, to make sure that all that information is available out there, and secondly, that any utilization which is unusual is accompanied by very careful, close monitoring and tracking of benefits and adverse effects on an ongoing basis. So I think, and essentially, are there more more effective methods that might be less risky, if you will, that can be utilized? So what other considerations have gone through? And I think all that is factored into the current prior authorization process.
Thank you, Dr. Tandon.
This is John Alekis. I happen to agree with Dr. Tandon. I don't believe that this is a cost-driven process. When I've seen some of the things that I've seen from a pharmacy perspective, I certainly agree that this medication is in fact needed. My whole issue is that I just want to make sure that the proper providers are in fact prescribing, and there is a review process for all new patients that are going to be subject to these atypical antipsychotics. So I totally agree with what Dr. Tandon has just stated.
The agency perspective, we care a lot about the citizens and the pediatric citizens of the state of Florida. We care about medication safety. We are, besides agency employees, we are parents. We are pharmacists. It's definitely a bigger issue than cost containment. So I just thought I'd slip that in there. Any other remarks from the committee?
One other point I'd like to ask, this is John Alekis again, regarding the University of South Florida review form, is it best to say that it's atypical antipsychotic review 6 years and under, or up to 6 years of age?
Up to 6 years.
It says 0 to 5 years here, so I would suggest that be looked at.
It's 0 through 5 years. So
0 through 5 years, okay. So it's, okay. So 5 years and under. Okay.
Yeah, 5 years and 11 months.
Okay.
To be.
In 29 days.
Gotcha. All right, thank you. 0 to 5.
Oh, PM.
Let's see. What else do I have to say? Another question.
Oh, think about food.
Mr. John Lalekis, are we going to send out additional information to the committee regarding some of the questions that we asked? For example, my questions on other provider types, recommendations. Are we going to make the recommendations about provider types as well? Where do we go from here? Suggestions?
This is Beth. Let me make a comment about the other category. That is self-reported on the form, and sometimes it is just checked off and the provider doesn't offer that information, so that isn't information that we always have. And that's why it's other and not specific.
This is John Lalekis. I can understand that, but my suggestion would be from going forward, or a recommendation that this committee may want to consider, is that other be in fact identified.
Right. Good.
I mean, when you're dealing with under 5 and under, or 6 and under, you need to know that.
Well, I think what Beth's saying too is sometimes the category is unknown. So are you okay with an unknown? If the provider leaves the box not checked, is that a reason to deny a prior authorization for a child who's waiting for care because they didn't tell us what specialist they were? You know what I mean?
My recommendation would be that here again we're allowed to give up to a 3-day supply in the retail environment. However, I think providers are pretty smart. Once they find out that they've got to identify who they are, they will in fact identify who they are on subsequent subsequent submittals.
Okay, thank you. We will distribute. We have minutes. We have minutes. Okay, we will distribute minutes to the committee with the summary of recommendations and a plan for. We're planning one more committee meeting.
Okay.
I'll let Beth take it over.
Well, how does the committee feel? Do we feel that one more meeting is adequate, or do we want to just plan a meeting at this point and then see where we go from there?
This is John Lalekis. I would suggest at least another meeting, and so I don't have any issues with participating in that.
Okay. Anybody else?
This is Dr. Isaac. I don't have a problem with another meeting. If we are going to have a meeting and there is data that's available to drive our decisions, even if it's inadequate data, I think it would be good for us to review that so we can make more informed decisions. I think one idea that has not been brought up is whether we should actually have any review process at all along these lines. Is this saving anybody any time, money, effort, or any illness or side effects? And I'd like to know if there's any data that the utilization, the review process, the way you're doing, is actually helpful. There's other ways, rather than interfering with the prescribing process, that can help to make the use of these medications as scientific and rigorous as possible, and one is by distributing information and our concerns to the pool of prescribing physicians. And the other is to inform patients about the concerns about these medications. And there are drug handouts that are given to patients all the time. FDA can do that, and maybe Florida Medicaid would like to make up a handout they can give to patients who receive these prescriptions indicating the appropriate use of that medication so that they can